Hello and welcome to this webinar hosted by Top Doctors. We are thrilled today to be joined by some of our top specialists for a very important reason. October is Breast Cancer Awareness Month. What started in the US in 1985 as a week-long event has become a global phenomenon and campaign to raise awareness, educate people, and funds for further research into the disease. So today we're going to be focusing on the importance of education and also to raise awareness. What can we do? So we are thrilled to be joined by some of our top specialists. As I mentioned, we have Dr. Tasha Gandamaharja, who is a consultant oncoplastic breast surgeon who practices in Brooks Hill. Thank you, Dr. Tasha, for joining us today.
Thank you for having me.
No
and
problem.
oh yeah, just to let you know, it's Buckhurst Hill.
Buckhurst Hill. Thank you. I focused so much on the pronunciation of the names that I forgot to think about the place names.
No, you did really well. It's just that somebody where's that? It doesn't.
No result. Buckhurst Hill, excuse me. We also have Mr.
getting my name right.
We also have Mr. Jaroslav Krupa, consultant oncoplastic breast surgeon in Leicester and Nottingham. Slightly easier names there. And we have Dr. Shiroma de Silva-Minor, a consultant breast oncologist based in London, in Oxford and Swindon. So thank you both as well for joining us.
Hello.
And for taking the time to speak to us today about such an important cause. So we're going to get started with our questions. And Dr. de Silva, I'm going to ask you, excuse me, slight issue here. I thought the technical issues were behind us, but clearly not. Excuse me now. So, perfect. Dr. de Silva-Minor, 55,000 women a year are diagnosed with breast cancer. It is one of the most common cancers in the UK. Why is it the most common in the UK amongst women?
Well, this is a really interesting question, and we know that the incidence of breast cancer differs between different countries and different nations. And it might surprise some to know that actually breast cancer incidence is much commoner in wealthier first world nations than if we consider countries like Africa or Southeast Asia. And this gives a clue to some of the risk factors that can play a role in increasing breast cancer risk. And in those poorer countries, we know that women generally have more pregnancies, they have a first pregnancy at an earlier age, they tend to breastfeed and breastfeed for longer. And conversely, when we think of women in more developed, wealthier nations, they tend to have fewer pregnancies, that tends to be at an older age, breastfeed for less time or not at all. And we know that all of those factors such as multiple pregnancies and breastfeeding are actually protective. And of course, add to the mix of obesity and diet and alcohol, and these all have an influence on having a very high incidence of breast cancer in countries not only in the UK, but in Northern Europe, Western Europe, and North America.
Absolutely, perfect. So it's estimated that 30% of breast cancer cases in the UK can be prevented through different lifestyle choices or changes. So what type of lifestyle factors put someone at risk? You mentioned alcohol there. Is there anything else?
Well, I think alcohol is a really important one that I would like to talk on. It always surprises me how many of my patients actually hadn't been aware that alcohol is an important risk factor in breast cancer. And the Million Women study, which was a study that was conducted by the University of Oxford, looked at healthy women and followed them up. So this was an observation cohort study which followed them up over many years, and they found that in terms of dietary factors, alcohol was one of the strongest links, and it causes DNA damage and influences estrogen levels, so it does have an impact on breast cancer. And in terms of breast cancer survivors, we know that alcohol can play an important consideration in terms of recurrence, and anything as little as 3 units a week could increase that risk. Now, that may be prohibitively too low for some, but at least it's about patients making an informed choice. In terms of diet, well, I could talk on this all day, actually. There's so many aspects of diet, not only what we eat, but when and how we eat it. In terms of the actual consumption of food, we know that keeping it to a very varied and fresh diet represented with lots of fruit and vegetables, cruciferous vegetables such as kale and broccoli, antioxidants like berries, fermented foods like kimchi, miso, and kefir all play a role. One of the commonest questions I get asked about diet is about sugar and whether sugar feeds cancers. And it's not so much the sugar that's feeding the cancer, but it's your body's response to the sugar. And so when you eat something which is highly processed or highly calorific, your body produces a huge insulin surge and insulin-like growth factors. And it's those that can actually stimulate cancer growth. In terms of when we eat is also really important, and there's an emerging body of evidence that suggests that intermittent fasting is really important, and it's been shown to have very many health benefits, not only in terms of the cancer, but also reducing blood pressure, stress levels, reducing stress hormones, and you can see how that could also have an impact in terms of cancer, but it's been shown to also boost your immune system. So having a period of fasting, so limiting your ideally 2 meals a day to 6 or 8 hours, which then allows you to have 16 or 18 hours fasting, can really have important health benefits, not least in terms of weight control. And of course, obesity is a big one, affecting a lot of these countries, in terms of what we discussed about first world countries, and obesity is a big problem that we see in first world nations. And we know that fat cells produce estrogens, and so it can certainly increase your risk of not only breast cancer, but endometrial cancers as well, which are both driven by estrogens. Exercise and activity, and we know that even in slim ladies who are at their perfect weight have a reduced risk if they're more physically active, and that also has an impact on bone health and muscle strength and things like that. HRT, that's a common one I get asked about. Well, this all depends on the duration of HRT exposure, the age that you were at when you were first treated with HRT, and also whether you're overweight, and the type of HRT, so combination HRT, whether it's estrogen only or a combination of progesterone and estrogen. But of course, we know that, so the risk is probably between 1 in 50 and in 1 in 200. So it's not a huge risk. And overall, Cancer Research UK estimate that it's about a 2% of all breast cancers may be attributable to HRT. But of course, on a personal level and on an individual level, patients, if they are concerned about their cancer risks, should discuss it with their GPs, because of course, as with every intervention in medicine, it's weighing up the pros and cons, and the benefits to you in terms of your bone health and your heart health may outweigh that cancer risk if you don't have any other risk factors. But yes, those are the big ones. And of course, smoking, you can't go to an oncologist without mentioning smoking. And although breast cancer is not as commonly linked to smoking as other cancers such as lung cancer, bladder, bowel, or head and neck cancers, but nevertheless, smoking can increase your risk of all cancers, and that includes breast cancer.
Perfect. Thank you. Very interesting, very insightful. I wasn't aware of the intermittent fasting, actually. I think there's a lot of emphasis on what we eat, and as you mentioned, not when we eat. So that's very interesting to hear. Dr. Ganda Mahaja, I'm going to come to you next, and we're going to talk about, of course, not all cases can be prevented, unfortunately. About 20% of patients have a family history of breast cancer. So the main question is it a coincidence, or is it a hereditary thing? Is it related to environmental factors, perhaps?
Yeah, so I think a lot of people seem to think that breast cancer is genetically linked. Somebody will come to say, "Oh, obviously I'm saddened I've been given a breast cancer diagnosis, but the funny thing is nobody in my family has got breast cancer." And actually, that is more common in that the majority of breast cancer happens just because it's not actually related to kind of a hereditary factor. So overall, actually only about 5 to 10% of breast cancers are hereditary. So the majority of breast cancers happen what we call sporadically. And the greatest risk factor, I would say, is growing old and being a woman. And those are the two things that we can't control. So yeah, only about 5 to 10% are genetically linked. And of course, you know, there are many factors that might contribute to why people get breast cancer. And at the moment, it's multifactorial. We can't really pinpoint to say, okay, you know, if you do this, then you're going to get breast cancer. We can't stop breast cancer from happening, but we can minimize the risk of breast cancer from happening. And as already mentioned, you know, kind of the lifestyle things, which are the modifiable risk factors, we can influence. And, you know, we can do as much as we can to help ourselves. But yeah, the majority of breast cancers just happen sporadically.
Mm-hmm. Perfect. Thank you. I suppose the question is if there is a risk of breast cancer in the family, just to be aware of it and to be a bit more vigilant, I suppose, is the main thing.
Yeah. I think, you know, there are gradations of risk. So you can either be, you know, low risk, moderate or high risk. And there are different factors that will determine where you fall in that risk category. So if you fall, you know, say, for example, you have a sister and a mother who had breast cancer at young ages, then potentially that's a genetic link. And in that case, you know, you might be prudent to see a clinical geneticist to have a genetic test. And genetic testing is really only offered to those who are at high risk of developing breast cancer. So if you say you have, you know, if your mother had breast cancer and an aunt had breast cancer, you may not necessarily be at a high risk. You might be at a moderate risk, which means that, you know, you might benefit from having a mammogram once a year from the age of 40 until screening age. But you're absolutely right. If you have, you know, if you're aware of members in the family who have had breast cancer, and that's on either side, so it's, you know, whether that's your mum's side or your dad's side, because actually it is as important to consider your father's history as well, then definitely raise that with your GP, and then your GP may refer you to your local family history breast clinic.
Perfect. Super. Thank you. So based on that, what we're saying here is being aware and knowing what to look for. So Mr. Krupa, I'm going to come to you and we're going to speak a little bit about the symptoms. It's really important to be able to recognize the symptoms. And that's what the aim of Breast Cancer Awareness Month is. It's raising awareness and being able to recognize the symptoms and be able to deal with it quickly if you know, if you feel the symptoms are present. So I suppose the most basic question is, what exactly are the symptoms, Mr. Krupa?
Yes, indeed, breast cancer can present with a variety of symptoms, and we should be aware of this. By far, the most common symptom is a breast lump. So breast lump or thickening of the breast is definitely one of the things we need to focus on and see a doctor if that happens. But also there are other symptoms which may not be that obvious, but can be important and relevant. So symptoms like nipple changes, nipple discharge, nipple retraction, we call it nipple reversion, when the shape of the nipple is changed. Also changes to the shape or contour of the breast. They can be sometimes quite subtle, but if they persist, they should be investigated. There are also patients who present with a lump in the armpit, which could be enlarged lymph nodes, but examination of the breast can be entirely normal. So that can be also a very important symptom. We also should mention that there are some situations where there might be some significant diagnosis behind very mild symptoms or relatively unrelated to breast. For example, you can have something called Paget's disease, which is type of breast cancer presenting as often as a skin change, like an eczema on the nipple or areola. We also sometimes see patients with a type of cancer called inflammatory breast cancer. This can look very similar to infection, breast inflammation, And work on these patients are treated for infection for a long time with antibiotics, and this does not resolve. So the essential in all this is obviously early detection. That's why we asking patients to examine themselves regularly, because the symptoms are subtle, but you examine yourself regularly, then you'll be first person to spot the difference. And obviously then you can be seen by your GP. So I think that's the probably main message from all this webinar, I think.
Absolutely. So sorry, something there. Perfect. Yes, go ahead.
So, Lauren, I just wanted to add to Mr. Krupa's very succinct description of early breast cancers, but just to remember that any patient who's had a previous history of breast cancer, it's really important to sort of listen to your body about any systemic symptoms, and patients are often not aware that recurrence can be elsewhere in the body, and that symptoms may go on for many months without them actually seeking help or being appropriately investigated. So it's really about not necessarily being anxious about every little ache or pain, but anything that's out of keeping with normal. Just really listen to your instincts. So, a chest infection that doesn't resolve after 2 or 3 cycles of antibiotics may be completely normal. But if it's persisting longer than that, maybe seek advice. Back pain after you've been moving furniture all weekend, again, very normal. But if it's going on a month down the line, waking you up at night, not responding to over-the-counter painkillers, really just listening to your instincts about getting that investigated.
Perfect. Thank you. Super advice, actually. I never thought about that. Just to go back to the symptoms, if that's okay, Mr. Krupa, do these symptoms appear in the early stage of breast cancer, or are they more linked to the more advanced stages?
So breast symptoms usually present for the early breast cancer relatively early, but as Shiroma mentioned, there are also these situations where symptoms far away from the breast area can be also relevant. So persistent back pain, cough, weight loss, things like that, and that's a very good point. We also have to remember that there are some clinical situations where early detection can be difficult. So, for example, young patients who naturally have often very dense, very lumpy breast, nodular breast, and find it difficult to distinguish between new lump or natural lumpiness or nodularity of the breast. So these patients often are diagnosed later than they should be. The other scenario that comes to my mind is the patients who are pregnant or lactating. We also have to remember that you can also develop breast cancer during pregnancy or during lactation. So lactational changes can make breast much more lumpy, and a lot of us assume that this is just linked to natural physiological changes, but actually it could be a sign of something more sinister. And also, obviously, patients with large breast, if you have a very large breast, it might be difficult to find a lump, especially if it's deep-seated. And we know that examination can detect probably about 60–70% of breast cancers, but not all of them. So we have to remember that not every patient will present with early symptoms or obviously with the same symptoms.
Perfect. Thank you. And I suppose that brings us to the next point, which is the importance of going for regular screenings and breast checks. So Dr. Gandhi Mahajan, I'm going to come to you for this one. It's a proactive approach rather than a reactive one to try and catch abnormalities as soon as possible, maybe without having symptoms. So what does screening actually involve?
Okay, so that's a good question. Obviously, women and men can have symptoms, and as described, if you notice any of the symptoms, you must get them checked out. But at the same time, there are cancers that don't present as symptoms, and these are the cancers that are found on imaging. So when we talk about screening, we normally refer to mammographic screening, and in the UK, we have a screening program which is run by the NHS. It's the NHS breast screening program. The screening program, for a screening program to exist, the cancer has to be common and easily detectable. And in the UK, we start at from the age of 50 until 70. That was traditionally the age range, and now it's been extended either way. So you'll get called between 47 and 50, and it's been extended to the age of 73. And what happens is you actually get invited to attend your mammogram. So, as a birthday present, when you turn 50, you'll get a letter to say, come and have a mammogram. And you attend, there are numerous places around the country. And obviously we're in the UK, so I can only refer to the UK. And you have a mammogram, and you have it every 3 years. You get the mammogram, and then the mammogram will be looked at by 2 consultant radiologists. So it's double read. That's the quality control. So, it's very well controlled that way. And then you get notified by letter. So if everything is fine, then you get told everything is fine, and then you'll get invited 3 years hence. However, if there is an abnormality, then you get what's called recall. So you get recalled back, and then you get either more mammographic views and potentially a biopsy. So that is the mammographic surveillance program here in the UK.
Perfect, thank you. And if somebody is interested in perhaps going to a screening themselves, so without being invited, how would one go about that?
So obviously, you can, I guess, self-invite to have a mammogram, and you can only do that through the private sector. And we normally start to do mammograms from the ages of 40. We don't do it younger than that because as a tool, mammograms aren't that helpful in young women because of the density of young women's breasts. And so we start, only if you're 40 and above, you can have a mammogram. So unfortunately, you have to do this privately, but from the age of 50, you'll get 47, 50, you'll get invited by the NHS.
Perfect, thank you. And I suppose this one's a bit more of a trivia question, but do you notice more people booking screenings or looking for screenings after Breast Cancer Awareness Month, October?
That's a good question. And I guess logically you would, that we do see peaks and troughs. And I guess I'm sure this is, true across the UK, across the country. When there's like October, of course, it's more front of center, and so people are more aware of it, and which is good. Although ideally people should be aware all year round, but I guess it's good to have a month where people talk about it even more. And we do see a spike normally in people coming to the breast clinic because they've been reminded, oh, I haven't actually checked my breast for a while, and actually maybe there's something not quite right. So there's usually more people would come in October, and I guess that's the point of breast cancer awareness, isn't it? To raise awareness, and if that is the result of Breast Cancer Awareness Month, then I guess that's a good thing. So
absolutely perfect. Dr. De Silva-Minor, would you like to say something?
Yeah, so just going to say that actually, obviously breast cancer is in the news a lot, and I think we often see a spike in patients presenting to our units when there's been a famous case, such as the Sarah Harding case, where I think it brought it to light for a lot of people, especially younger women, to go and have their breast checked. And we had a big spike in referrals through GPs at that point. But I think generally people being much more aware because of celebrities and people in the public eye being much more vocal about it is also really helpful for breast cancer, because of course cancers like bladder cancer, which affects old men, smokers, really doesn't get very much media time or attention or the same sort of spotlight.
Mm-hmm. No, absolutely.
Sorry to interrupt. No, I agree. There's definitely, we hear about the effects, right, of celebrities. So there was, the Angelina Jolie effect that meant that, there was a spike in people wanting risk-reducing mastectomies, and the BRCA gene kind of talk was highlighted more, or the high-risk genes really. And then I think there was the Kylie effect when she got breast cancer, was affected by breast cancer, Sarah Harding last year. So definitely, I agree. Definitely, when there are famous people, there's definitely a spike as well. So whenever breast cancer is a cancer that is talked about a lot, and so the awareness is there, but it becomes more so not only during this month, but also when when famous people unfortunately are affected as well.
Of course, yeah. I mean, it's obviously very, very sad to see, but it is the, I suppose, silver lining of the situation is that this disease is getting spoken about and we're given a platform to be educated about it. So we have to consider that as well. So if a mammogram comes back and there is an abnormality in it, or any screening comes back and there is an abnormality, excuse me, with it, Mr. Krupa, I'm going to come to you for this. What is the next step if there is an abnormality detected?
So Tasha already mentioned the process for the patients who attend screening mammograms, but many patients, majority of patients present through the symptomatic pathway, as we call it. That means that they present with the symptoms. And obviously, many of them will see the GP first, and then we refer to the breast clinics. But in my practice, I see a lot of patients who self-refer to private clinics as well for the assessment. So we usually follow something called triple assessment process, which includes clinical examination, some form of breast imaging tests, and some biopsies. And this is a very, very robust way of assessing every new abnormality in the breast. And if we follow this, we would miss very, very few cancers. So this is kind of national and international standard. Obviously, the choice of imaging is individual depending on patient's age and particular situation, but most of the patients will get mammogram if they above age of 40. Under 40 would get ultrasound scan. Many patients would get combination of those. We also do more and more complex imaging tests now, like contrast enhanced mammography or breast MRI scans. And these pathways can be very, very tricky and very complex, but it's important to establish the stage of the disease at the very, very beginning. That will also affect some decisions about treatment, which can be very different for different patients. It's important that tissue biopsies performed at this visit, and this will be then assessed at the so-called MDT meeting, which involves different specialists working together. It will be surgeons, oncologists, pathologists, radiologists, breast cancer nurses. So the whole group of people who look at the same problem from different perspectives. All the imaging tests, patient's history will be reviewed, and also histology will be assessed. And this is where the treatment plan is formulated, and this is to make sure that the patient gets a best, optimal plan for the treatment. So that's the usual scenario before we move on with first treatment.
Perfect. And that leads very nicely to the next question. What type of treatments are available for someone with breast cancer? And how does it differ between the different stages?
Again, it's probably a couple of hours conversation to be fair,
yeah.
but we can say that generally speaking, there are several treatment options available for breast cancer patients, and those include surgery, radiation therapy, hormone therapy, chemotherapy, immunotherapy, and so on and so on. A lot of patients will get combination of these treatments. Some of them will have all of those treatments, and others will have only one or two treatments. So very much decision like this is individualized. Luckily, there is a huge amount of research going on regarding breast cancer, and we constantly have new treatments emerging, which obviously give us more options for treating breast cancer, which is great. But also that means that the treatment nowadays is much more complex and much more individualized. We like calling this personalized treatment, and I think that's probably a good way of describing this. Some patients would have surgery first as a first-line treatment, but many patients will have something called neoadjuvant therapy, which is like an induction treatment before we proceed to surgery. It could be chemotherapy or hormone therapy. So very much. This is obviously good news for us. We have more options available. It can be quite confusing for the patients because, when they talk to their relatives or friends for treatments, they can have completely different treatments. And obviously, it's important to appreciate that this decision is very individual.
Absolutely. Perfect. And I suppose one of the big questions people probably have is surgery. When does surgery come into the question? How often is it used as a treatment option?
Surgery is very important. Obviously, I'm biased being a surgeon, but it's often first-line treatment for majority of patients with early breast cancer, particularly. And again, the options are very individual. Some patients would have some induction treatment to reduce the volume of the disease, or we call it downsize or downstage disease. So we have very powerful treatments now. They can reduce the size of the tumor, can make the surgery much more predictable, easier, and less invasive. But majority of patients would progress to surgery first as a first-line treatment. And obviously, you have different options, having breast-conserving surgery or mastectomy, which is a bigger operation, we remove whole breast tissue, or we can often offer something called oncoplastic surgery, which is a combination of cancer removal with some breast reshaping. So I have a huge range of surgical options. And again, this is a very individual decision, and that's why you need to see the surgeon to discuss your options. We also usually perform some form of lymph nodes operation in patients with invasive breast cancer. We're trying to reduce the complications or long-term side effects of this treatment. Therefore, there is a trend towards de-escalation of cancer surgery, but still it's a very important treatment because first, it can remove cancer completely, can provide very good local control. That means that the chance of cancer coming back locally is much less. Provides very important information about situation of the lymph nodes, so-called staging. So helps our oncology colleagues to plan treatment, and obviously gives very important information about patient's prognosis. So I still believe the surgery is a very important treatment.
Of course, absolutely. I'm going to go to Dr. De Silva-Minor now, because we've spoken to a surgeon. Let's speak to an oncologist. How is the most suitable treatment for a patient chosen?
Okay, so following on from Mr. Krupa's helpful description, I mean, we have decades of experience and clinical trials, which we call evidence-based approach, so that all treatments for breast cancer is done in a very evidence-based way, so that we know what the optimal treatments are for any particular tumor type. So breast cancer is not one disease. There are 4 distinct subtypes within that, and each of those can be treated very differently and can have different outcomes. Central to all of that is the patient. So of course we have protocols, but I'm a great believer in really empowering the patient to make the right decisions for themselves, and so making an informed decisions about the different ways that the breast cancer can be treated. And there are sometimes there is more than one approach. So as Mr. Krupa mentioned, you can have neoadjuvant chemotherapy, so where you do the chemotherapy as the primary treatment followed by surgery. But there are times when that can be reversed, so you have the surgery initially followed by the chemotherapy as needed. All of these decisions are discussed and made collectively with the multidisciplinary team meeting, so with pathologists, oncologists, radiologists, surgeons. So it's never a unilateral decision. So yes, it's quite a holistic way of considering the patient, but also considering what the best treatment is for the tumor.
Mm-hmm, absolutely. How much say does a patient have normally in the decision?
Well, they have absolute say. So we can make all the recommendations, and there are patients who decide not to do any of those, and some will be absolutely fine. Others, unfortunately, will run into problems, and that's part of the problem, that we still don't fully know how to identify those patients who are most at risk. I mean, we do have a lot of tools in our armory to identify high-risk patients now, much more now than 10 years ago. So genomic profiling with Oncotype DX, for instance, can really identify those patients who may most benefit from chemotherapy, whereas even up to about 5 years ago, we were making those decisions just based on the appearance of the tumor and the lymph nodes. But to answer your question, yes, the patient is very much in the driving seat.
Perfect, thank you. And last question on this anyway, can breast cancer be fully cured?
Absolutely. So overall, about 8 out of 10 patients will be cured. And it depends on a number of different factors. But when you consider that overall breast cancer mortality has halved over the course of the last 40 years or so, and there's been some incredible developments even in my 20 years as a breast oncologist. But the number of things that it depends on, one is the subtype. So we know that, as I mentioned, there are 4 different subtypes, and triple negative breast cancers in particular can be much more aggressive. However, the exciting thing is there are lots of new developments now to particularly target those, and immunotherapy only really works in triple negative breast cancers. So there is much more optimism for those sort of tumor sites. And the other big one is stage. So identifying cancers at an earlier stage means that they're much more likely to be cured. So a stage is really how far has the tumor spread? Is it just in the breast? Has it gone to the lymph nodes? Is it further afield? So if it's in the breast or lymph nodes, it's still very much curable. But unfortunately, if it's spread further afield to other organs, then it's considered stage 4. But the good news and the optimism is that we are now, with the developments over the last few years, really starting to get into a new era where these patients are being treated almost like a chronic illness and living for many years with metastatic disease. And the outlook is much more hopeful. And there are some patients, even with metastatic disease, who might have oligometastases, which are a few number of secondaries, which could be targeted with high precision radiotherapy, and then treated with targeted therapies, and could be possibly cured. But yes, it's a very optimistic time.
Fantastic. So,
And I just want to, if I may, just
of course, yes.
follow on from that discussion. 2 things really. As discussed, the outcome is very good. Prognosis is very good, but we're not at a time yet, unfortunately, that breast cancer is 100% curable. So I think it's there are people that are living with breast cancer, and they are living with stage 4 breast cancer as well. And it's encouraging to know that prognosis, on the whole, remains good. But I think we still need to do a lot of research, especially for the group of people who are living with stage 4 breast cancer. And 31 people die every day from metastatic breast cancer, and it's still quite it's something that we need to do more about. So I thought that's quite important to highlight. And the second thing is about your question about patient choice, and I think all the doctors will, of course, yes, that's ultimately the patient has the ultimate choice of what they want to do. We as doctors are here to guide them in their treatment. We offer what we feel is the best treatment for them, whether that's surgery, chemotherapy, radiotherapy, hormones, immunotherapy, whatever the treatment plan is. That is what we decide is the best for them, but ultimately they decide. So if we say, okay, well, we think you would really benefit from chemotherapy because your Oncotype DX recurrence score is very high, but then they say, well, actually, I don't want it. Then that's down, that's their choice, and we can only do our best to kind of guide them to that. And I guess it's important for patients to realize that they have choices, and it's important for them to realize that, okay, if they are not particularly comfortable with this, then maybe they need to look and go and get a second opinion to find other advice, other recommendations, because ultimately it's down to them. We're here to guide treatment, but they decide what they want to have.
Absolutely, I can understand that. Super wonderful. I suppose one question that's come up there as we're speaking, and I'd just like to ask, and open to anyone who would like to answer it, if it is a case of recurrent breast cancer, so the first treatment works successfully and then a few years later it comes back, is the treatment plan tweaked? Is anything changed in that, and is a different approach taken? Whoever would like to answer that.
Well, I'll jump in first. So of course, from the primary tumour recurring, probably in about 85% of patients, it's exactly the same tumour that's come back. But of course, the treatment approach is different. And then of course, the remaining 15%, the tumour might have actually changed to a different subtype. So the first thing is to establish exactly what we're dealing with and how far this has spread. So usually if it's spread further afield, then it's treatment that is what we call systemic treatment, so chemotherapy or immunotherapy or targeted treatments that would travel throughout the body and deal with it wherever it was. If it was just in the breast or lymph nodes, then my surgical colleagues could then step in, and that could still be treated with curative intention. So it all depends on exactly where that recurrence is. And to answer your question about what treatment they would have, again, it's identifying the tumor subtype. But of course, we know that this time around, it's less likely to be cured. But we know that targeted treatments can be very effective. And so for distant disease, surgery usually doesn't play a significant role. It's more so medical treatments.
Perfect. Super. Anybody else like to add anything?
No, I mean, I think, if somebody has a recurrence, it's, as mentioned, it depends on where the recurrence is. So if it's, a local recurrence, which is either within the breast after somebody who's had a lumpectomy, then, surgery would be done. And then, for the kind of drug manipulation will then be added. The other thing that I ought to mention is even after a mastectomy, people need to be aware that recurrence can still happen. So if you go flat chested or you've had a mastectomy and a reconstruction, it's still vitally important to be aware and examine either the chest wall or the reconstructed breast, because you can still get a recurrence. So local recurrence, either in the breast or the armpit, axilla, surgery is usually what we can help with, surgery. But then distant disease, Shrima, our esteemed oncology colleague, who's very clever and gives lots of drugs, can help rather than surgical treatment. Yeah.
Perfect. Super. Well, I think that wraps us up on how to be aware and general education around breast cancer today. Before we finish up though, I'm going to ask everybody just to share their one piece of advice for Breast Cancer Awareness Month. So what do you think is the most important thing that women or even men should be aware of and should be looking out for? I'm going to start with Mr. Krupa.
Yeah, I think probably the one really important take-home message would be examine yourself regularly. If you know your body, you'll be the first person to spot changes, and you have much better chance to have very effective, very successful treatment. And that applies both to newly diagnosed cancers or cancer recurrences. So that's the bottom line. Once you know that there's a problem, just go to the right person to have assessment, and you'll be well looked after. If you present late, then your chances of cure are significantly diminishing. And it's just really sad sometimes to see patients who present very late when we know that we missed the boat of treating them successfully. So that's my take-home message today. Thank you.
Perfect. Thank you so much. Dr. de Silva-Minor.
So I guess I would say that it's important for all of us, doctors included, just to examine our own lifestyle. And there's always something that can be improved. And I'm very conscious that I sit in clinics and advise patients about exercise and diet, and realize that actually I do an awful lot of sitting in a car or sitting in clinic. And there is something that we could all do. And even things like sleep patterns. And we know that there can be a link with a lack of sleep and increased breast cancer, and so that's something I could particularly improve in my lifestyle.
Perfect, very honest. Thank you very much. And last but not least, Dr. Tasha.
Tasha, sorry. Fine. Yeah, that's fine.
You got through an hour and a bit.
Tasha. No, well
Excuse me.
No, not at all. My name is Tasha, so you can call me that.
Perfect.
So yeah, I mean, I think finally, I guess to wrap it up, my advice would be don't panic. Okay, so if you find something that is not quite right, that is not your normal, it doesn't necessarily mean it's something horrible and it being a cancer. Just because you have a biopsy doesn't mean it's going to be a cancer. So don't panic. If you find something not quite right, just go to see the GP, get referred to the breast unit. We'll look after you. But it's best to have it looked at rather than, not going. Don't panic, just get it checked out.
Stay calm. Perfect. Well, again, thank you all so very, very much for taking the time to speak to us today on behalf of Top Doctors and all the viewers. It means an awful lot. So we can only say thank you again. And hopefully everybody who's watched this found it very, very interesting. I know for a fact that I did.
My pleasure.
No
Thank you.
So thank you again.
Take care.
Thank you very much.
Wonderful.
Bye-bye.
Thank you.